So that, one of the things I think physicians reach for is aspirin. And I wanted to, make sure to talk about aspirin tonight, just to review the data regarding aspirin. And I would like to start with, again, another meta-analysis or synthesis of data by Dr. Robert Hart, who's a stroke neurologist. He's now at McMaster in Canada. But he published this back in 2007, and I just think it's very illustrative of aspirin and its role with atrial fibrillation. And, again, if you look at favors warfarin or favors the antiplatelet, you can clearly see that there, I think, is only one Afisac 2 that was even anywhere near saying that aspirin therapy was going to do the job when it comes to reducing ischemic strokes in atrial fibrillation. So that was the first bit of data, I think, that made us rethink aspirin's role. And then for me, there's really two studies. I think the Averroes study really was definitive, in my opinion. If we have any questions about it, that would be great. But the Averroes trial, basically asked physicians who had clinical equipoise, so that the physicians had to be torn about whether they thought aspirin or apixaban would be the better choice for their particular patient with atrial fibrillation. And this trial was actually stopped early because of the dramatic efficacy of apixaban, which I think you can see on the left, really clearly highly statistically significant. And I think the surprise to all of us was that when you looked at the major bleeding that was occurring in this Averroes trial, at least, through the first full year, there's really hardly any difference. And you can see the hazard ratio of 1.13, which means that there was a 13% increased risk of major bleeding. But again, that confidence interval is very wide, and that tells you that there was no statistical difference between those two curves. So, one could say, well, I could actually interpret this in two ways. One way is that, I would say that, well, geez, maybe, apixaban is safe. But I think that the truer, well, it's somewhat truer, I suppose, is that aspirin, as we get older, is actually harmful. And I don't think that our physician community and healthcare providers really embrace that. I think that we've always thought that aspirin was relatively innocuous and harmless. And, we have even an 81 milligram, baby aspirin that we think doesn't really cause harm. But we know that it does cause harm, and it's especially can induce, obviously, gastritis and ulcers in the stomach, especially over age 75. So that I think that this trial, for many individuals, really said if you wanted to reduce ischemic stroke and atrial fibrillation, you're not going to be choosing aspirin. And part of that is, again, just to reiterate, is that the hazard ratio of 0.45, means that there was a 55% reduction in risk with apixaban for ischemic stroke, or actually the stroke there is combined. It's intracerebral hemorrhage or hemorrhagic stroke and ischemic stroke. So with the major bleeding, again, with aspirin compared to apixaban, I think that was really a surprising finding. Such that if you look at the European Society of Cardiology, and I think all of us, certainly in the U.S., embrace these guidelines as well. They're excellent. They're very clearly written, and they're actually very much aligned with the American. There's a few areas of departure, but not many. But clearly, they actually this year for the first time stated in the guidelines that the antiplatelet monotherapy is not recommended for stroke prevention and atrial fibrillation, regardless of stroke risk. And this also is the first time that they attached a harm designation to this particular recommendation. And these can be downloaded. I have these guidelines on my desktop, and I really refer to them quite often. So I think that, it's a very good resource if I can't remember how many pages, but if you really wanted to get some background reading, they're excellent. So we could say, well, what about improved risk stratification? And I wanted to spend just a little bit of time about hemorrhagic risk scores because, being a methodologist myself, developing these large population-based programs, you can see that we try our best to discriminate risk. But this is an issue for the bleeding scores. And I think the most important is that many of these factors are the same factors that cause ischemic stroke and atrial fibrillation. So, for example, if you just look at the HAS-BLED score, which I think is the one that we probably use more frequently, hypertension is a risk factor for stroke. We know that abnormal renal function is a risk factor for ischemic stroke. We know that having had a stroke is a very potent risk factor for stroke. It's part of that CHAS-VASc score. Certainly bleeding makes sense. Lower INRs if the patient had been on warfarin. Elderly, when they developed it, they actually just made the cutoff at greater than 65, which, I think today elderly is closer to 80. And certainly drugs or alcohol being 1 point each, so that the ability to discriminate or use any of these factors to really say that this patient maybe shouldn't be on an anticoagulant, I think is really sort of not the correct way to be using these scores. In the way that they were intended to be used was to, look at each one of these factors and sit with your patient and think, how can I prevent the bleed from occurring? So, the common sense here is hypertension. If we have patients without well-controlled blood pressure, they really shouldn't be on an anticoagulant because having uncontrolled hypertension is a very potent risk factor for intracerebral hemorrhage. So blood pressure control is critical. It's something that we can do something about that. It's also a big risk factor for ischemic stroke. So, what other things on here can I try to, change or alter? Certainly if there's a bleeding history, and I'm seeing this patient from they just moved into Massachusetts or something, like I'm going to really want to interrogate and understand, like, was there a workup? Do I understand why this patient has had bleeding? Was it diverticular bleeding? What kind of bleeding? Because that's the way to hopefully prevent it from occurring again, is to be sure that it was worked up comprehensively in the first place. And certainly drugs or alcohol, and I think that, we just sort of looked at aspirin and antiplatelet therapy and how that really increases the risk of bleeding. And any type of binge drinking, alcohol in excess is going to increase the risk for gastritis as well as a number of other things. So I think right now, things have changed, even with the European guidelines, that originally their algorithm included a box that said, you should calculate or look at the HAS-BLED score and then, made some recommendations. And again, please, we can talk about this if there's, questions regarding the bleeding scores, but, really never meant to be a decision breaker about I should prescribe it or I shouldn't. It was really to identify the factors that drove bleeding risk and how can we possibly make a change in this to help our patients. So that as I was just discussing, if you look at the 2012 European Society of Cardiology guidelines, here you can see that if you had a CHAS-VASc score of 1 or 2 or greater, that oral anticoagulant therapy was suggested, recommended, certainly for 2 or more. And it said to assess the bleeding risk or using this HAS-BLED score and to consider patient values and preferences. And the Europeans, our European colleagues, actually had preferred the NOAC, which was designated by the solid line, compared to certainly, well-controlled warfarin, vitamin K antagonists are also very good. They're just saying the ease, the shorter half-life, wider therapeutic window, that they were given the preference over VKA in Europe. So that in addition, they have also published something called the European Heart Practical Guidelines, which you can also download. It's from Europace there, you can see. But I think this is important because they're saying that most patients with a high CHA2DS2-VASc score, and high here really means 2 or higher, would benefit from oral anticoagulant treatment, even if the bleeding risk is high. Only in rare patients with a relatively low stroke risk with an extremely increased risk of bleeding may the withholding of OAC be considered. You know, and the other thing I almost forgot to mention that is important is that when we look at the Hasbled score, the Atria score, that hemorrhages score, it's really it's a score that's going to predict aggregate major bleeding. So there's GI bleeds that are in there. There could be, you know, a severe nosebleed in there. I mean, these are all bleeds that had to meet a definition. It's a standardized definition, and that bleed to be counted had to cause a 2-gram drop in the patient's hemoglobin and or a 2-unit or more transfusion of blood. So that is the International Society of Thrombosis and Hemostasis definition for a major bleed. And then in addition to that, certainly it's going to be a critical organ bleed, like pericardial, for example, you know, the sac of the heart. Retroperitoneal in the abdominal cavity is considered a critical site bleed, and certainly an intracranial hemorrhage. But the vast, vast majority of those bleeds are going to be GI in nature. They may be soft tissue in nature, but they're not really, the vast majority will never really come close to the mortality or the neurologic deficit of an ischemic stroke. And I think it's important to always keep that in mind, that we're not predicting intracranial hemorrhage. We're predicting all hemorrhage that would be considered major. So that if we look at this next slide, and this is coming out of, I believe it was Sweden, a very large population-based study, 182,000 people, 678. And what these investigators did is they put the patients into each of these 4 squares. So that in the upper left, you have individuals with a CHA2DS2-VASc score. That's really 1 to 2. And the highest Hasbled score. So here we have that Hasbled score. Remember, it included hypertension, prior stroke, history of bleeding, Lower INR, age over 65, drugs, which was aspirin, alcohol, any kind of non-steroidals. But you can see, and this to me I think is illustrative, that, you know, in that group that has the lowest CHA2DS2 score, so that they have the lower risk of ischemic stroke, but they have like the highest risk, higher risk of bleeding. And you can see that these 2 curves, they're called Kaplan-Meier curves or survival curves, that they start to separate very early, even within that first year, showing you that when we look at all-cause mortality, ischemic stroke, and intracranial hemorrhage, that there's a benefit to being on oral anticoagulant that you can see by the separation of those curves and a highly statistical p-value there. So I think that's important. So how do you use a bleeding score in practice? And this is what I have just been saying, that I think it's difficult because they overlap with the stroke risk factors, that the major bleeding that we're predicting is very heterogeneous, from a nosebleed to an intracranial hemorrhage to GI bleeding, and that they're irrelevant, really, for the vast majority of patients with atrial fibrillation, because the benefit of anticoagulant therapy is so great. And I think that really is coming from that Freiberg study that demonstrated that even among that group with the highest risk of bleeding and the lowest risk of stroke, that there was still a net clinical benefit for being on an oral anticoagulant if you looked at the aggregate measures of all-cause mortality, ischemic stroke, and intracranial hemorrhage. So because of all of this additional data and evidence, I mean, what you now see in the European guidelines is something very different. So that now you can see if the CHA2DS2-VASc score is 2 or greater, oral anticoagulation is indicated, and assess for contraindications and correct reversible bleeding risk factors. So they've gotten away from like calculating a bleeding score and just really said, hey, sit down, know your patient, get the history, and, what can you do to try to minimize anything, happening to your patient after they are prescribed an anticoagulant. And then again, we have the choices of NOAC and vitamin K antagonists. And if there's questions about the left atrial appendage occlusion devices, I'm certainly happy to talk a bit about that, but I would imagine that there's probably going to be other programs devoted to that. So the modifiable and the non-modifiable risk factors, those that we consider modifiable, as I had already said, is hypertension. Certainly highly variable INRs. We've got to figure out why that's the case. Medications that predispose to bleeding. I mean, our patients with pain, it's really a challenge because we absolutely cannot prescribe non-steroidal anti-inflammatory drugs if you're on an anticoagulant. A medication like ibuprofen will increase the risk of GI bleeding by about 19-fold. So you really cannot combine non-steroidals with these agents. As we had discussed, excess alcohol, I think, is obviously a huge risk factor. We often forget that binge drinking, not clear what the mechanism is, but it's a risk factor for intracranial hemorrhage in and of itself without any type of trauma or fall. So I think that's important. And when we talked about anemia, impaired renal function, impaired liver function, reduced platelet count or function, when I think about anemia, I would like to know why. I want to be sure that the patient doesn't have any, polyp or, called cancer that I'm not aware of, so that I would clearly, with anemia, certainly iron deficiency anemia, the standard of care is to do an upper endoscopy and colonoscopy to be sure you're not missing something. And then with impaired renal function, impaired liver function, you're just going to be complete and comprehensive and make sure that you're not doing something to worsen the renal function or the liver function. And then clearly the non-modifiable risk factors are age, history of major bleeding, previous stroke, a dialysis-dependent kidney disease, cirrhotic liver disease, malignancy, any type of genetic factors. But we're not really doing genetic factors, really, and nor are we doing a lot with the biomarkers to predict bleeding. So I'm just thinking now, how would you use this information? And as we already said, we would be addressing those modifiable risk factors. That's how I use this as a checklist. I also follow my high-risk patients more closely. And I'm also sure that they're aware of warning signs of bleeding. Many patients don't recognize melena. They don't know what that is. They assume that their stools look dark because they're on iron or something. But, I think that it's important to educate patients on what they need to be looking for when they're on one of these blood thinners. And to obviously reconsider risk benefits for those patients with what I would argue a high bleeding risk and a very low risk of stroke. I have alluded to these different combinations that we use so commonly, and I think that this study from Canada really illustrates the dangers. This one here was another study that was coming from the UK, a large general practice research database. And here, look at the odds ratios of GI bleeding, so that if you're on clopidogrel and a non-steroidal, or clopidogrel and aspirin, warfarin and a non-steroidal, warfarin and aspirin. So if you look at the drugs when they're used by themselves, you can also appreciate that the odds ratios are clearly not zero with aspirin and clopidogrel, warfarin. But when you start to add in an antiplatelet agent with the anticoagulant, that's really when you start to get the increase in the GI bleeding, especially. So again, going back to the recently revised European guidelines from 2016, again, they have another harm recommendation, and this is that the combination of oral anticoagulants and platelet inhibitors increase the bleeding risk and should be avoided in AF patients without another indication for platelet inhibition. So that I think we really do all that we can to try to minimize these combinations. And certainly for individuals with acute coronary syndromes or they just had a stent placed, that's clearly a high-risk, patient population that with atrial fibrillation clearly needs to be protected from all these different vascular beds. So in that situation, several studies now are trying to demonstrate that, we don't need the aspirin plus the clopidogrel plus the anticoagulant, that the WOAST trial showed us that with that population, even if we drop the aspirin at the very beginning of the acute coronary syndrome, it seems like that reduces the bleeding. So if we just go to the new oral anticoagulants, they're not that new any longer, but the DOACs or NOACs versus Warfarin, I think it's really, really critical. Again, I'm not sure if we have a lot of patients on the line. I hope we do. But it's very important that we understand what the how short of an onset these drugs have. That's critical. If we think about warfarin, it takes 3 to 4 days before you really get that maximum effect, the maximum, I guess we could say, concentration. But if you look at all of these others, it's really 2 hours. So it changes everything. The perioperative setting, it's very important to know that when you restart your rivaroxaban, dabigatran, or apixaban, edoxaban, you're going to be fully anticoagulated within 2 hours. So you have to be critically sure that you've achieved hemostasis with your biopsy or with your polypectomy or whatever other procedure, because it is really akin to being on, an unfractionated heparin drip, back in the day with full anticoagulation. So that's critically important. The other huge departure with these drugs, in addition to the time of onset of full effect, is the half-life, which again is the amount of time that it takes for 50% of the drug to be metabolized. So with warfarin, if you look at an elderly population, and elderly for me is definitely going to be at least over 75, the half-life can actually extend to 60 hours, 6 to 0. So warfarin tends to really hang around a long time after you stop the drug. And again, that's it's a striking difference compared to dabigatran and the factor 10A inhibitors, because here you can see that most of these drugs, 50% of the drug will be gone in about 10 to 12 hours. So it's not 40 to 60. It's really a half-life of about 12 hours. It's very important. And then I think finally, just to understand the pharmacokinetics, is the renal clearance. And let's recall that warfarin is almost exclusively metabolized by the liver. So these drugs are a distinct departure from warfarin because all of them, to some degree, depend on the kidney to clear the drug. So with dabigatran, it's about 80% dependent on the kidney. Rivaroxaban, about 33%. Apixaban, 25%. And edoxaban, 50%. So, again, I think that that's important to understand because it's going to affect how rapidly someone is able to clear these drugs, because it does include, as I said, to some extent, kidney function. So that the FDA does recommendations for the NOACs in patients with atrial fibrillation based on the creatinine clearance. We don't have to go over each one of these, but it's really based on, kidney function. So with the apixaban, it's either 5 milligrams twice a day, or it's going to be 2.5 twice a day. Important to remember for apixaban, you need to have 2 of 3 criteria in order to justify that 2.5 lower dose. And those criteria are age, 80 or older, weighing less than 60 kilograms, or a creatinine of 1.5 or greater. So you need 2 of the 3 for those for apixaban. And then with dabigatran, remember we don't have the 110 dose, which the rest of the world does, but we have a 150 milligram dose, which is twice a day, as is apixaban. And then for a group with really quite advanced renal dysfunction, I don't think any of us are really using these drugs less than 30 mils per minute yet, because we have very limited experience with them. But that would be for dabigatran anyway, the 15 to 30 creatinine clearance is 75 twice a day. And then for edoxaban, it's 60 milligrams is the usual dose, but you would cut that in half to 30 once the patient develops moderate or stage C renal impairment, which is a creatinine clearance of 31 to 50. And then with rivaroxaban, again, somewhat similar with 2 doses, 20 or 15, dependent on the kidney function. So one of the most, I think, perplexing things of being involved in some of these trials is the fact that many of us, for whatever reason, and I wouldn't say us because I clearly would not do this, but I don't understand how physicians are choosing the lower dose. I think if you look at this particular slide is really telling that in the United States, Germany, Canada, Australia, the United Kingdom, I mean, there are many doctors that are choosing the lower dose for these agents. Rivaroxaban would be the 15, dabigatran, again, 110, we don't have in the United States, which is why it says 0. And, I do think that there's a trade-off when we choose these lower doses, and I think that it's important that physicians, our PA nurse practitioner colleagues, I mean, everyone who's out there, like with these new agents, to be choosing a lower dose. You really have to, I think, be able to justify that, and I don't think the data would always support that this is somehow going to give you a lower risk of bleeding. What it's really going to do is increase the exposure to an ischemic stroke. So I think it's just really important to remember how to dose these drugs appropriately. And we know from the Engage Kidney trial, I think this was so informative, that they had a lower dose arm to that trial, which was 30 milligrams, and then some individuals had it further reduced to 15. But within that low dose of that arm for edoxaban, we found that it did indeed expose patients to increased ischemic stroke. And when you look at the risk, it was a 41% increased risk of having an ischemic stroke. So again, we're fearful of bleeding, and I think we don't want to feel like we're causing bleeding, but it is very hard to see a patient suffer an ischemic stroke. And I'm sure, physicians that have been in practice as long as I have seen it, and it's really heart-wrenching to have a patient not make it because of an ischemic stroke. So just sort of a little bit of advice, I guess. The other thing is that we all read the literature, we consume the literature, we're reading, all of these new studies that are coming out, and I just want to put in a big plug to beware of registry data, when they say we followed, X number of patients through whatever pharmaceutical database or whatever, because they have to let you know what dose is being used. Because if I don't know how many patients coming out of Germany or how many patients in the study from Spain or from the United States, like what percent of these patients was on the lower dose of rivaroxaban or edoxaban or apixaban? Because how could I possibly interpret the bleeding the bleeding rates or the ischemic stroke rates if you don't know the dose. And so I think, always look at the method sections, look at the tables, make sure that that critical piece of data is there, because I think, without that, we could be making some faulty conclusions. So the left atrial appendage closure, I didn't realize, I guess I do have one slide on this here. This has been approved in the United States. It's called the Watchman. And, initially this was really associated with about a 6% rate of pericardial effusion. I mean, it is an invasive procedure. And I think, clearly this is not in the mainstream. I think these are going to be certain patients that probably can really not be on an anticoagulant long term. And I think that's likely where this will reside. But again, as different centers in the United States get more and more experience and these particular devices get more and more refined, they may become more commonplace. But for now, I think it's just a reserved patient population that would actually be considered for this type of a procedure. So again, going back to our European guidelines, there is some recommendation, but again, very focused on which groups might actually benefit from that type of occlusion of the left atrial appendage. So I have just a few slides, I think, on venous thromboembolism, because this is, again, like, what are we doing the right thing? Because what we do now, remember, if you've had a provoked clot, we usually, if we know what the risk factor was, we know, what caused it. It was surgery, it was trauma, it was immobilization, it was lengthy travel, estrogen therapy. You can treat that patient for 3 months and then you're really done because the risk factor is gone. But for the unprovoked, these patients, we're not exactly sure what caused their clot. We can't come up with a transient or reversible risk factor. So for these individuals, oftentimes, it may be lifelong for individuals, certainly with active cancers, antiphospholipid syndrome, inflammatory bowel disease, and other things. So when we try to think about minimizing the risk of bleeding, we at least want to be sure that we've done our due diligence on, is this a provoked or an unprovoked clot, because that's what drives the duration of the anticoagulant treatment. And we know, just as I had said, that the risk of recurrence with a provoked clot is actually only about 3% per year. But as we have those other, either the idiopathic, where we really don't have any idea as to what caused it, or there's a continuing risk factor like cancer, the recurrence rate for these venous thromboembolic events is over 10%, even in the first year. And on this slide, if you just focus on that red line, this is the cumulative incidence of recurrent VTEs for that provoked versus the unprovoked clot. So that if you look at about the 5-year mark, you're upwards of 25%. And I think that's really the reason that we have really been a little more aggressive, I think, in recommending keeping these patients on this treatment because of that high risk of recurrence. So I think this is my last slide, and hopefully there'll be some questions. But when I think about effective use of DOACs and NOACs in clinical practice, this is kind of my top 8 thoughts, is that, the patient selection is really critical, because I think adherence is important because these drugs have a short half-life. So, warfarin, it's burdensome, it's problematic, it can be all over the place, it's not an easy medication. But if you have patients that need some extra help, need navigation, need something, like get them enrolled potentially in, your clinic, or have them be followed at least, the first month, the third month, the 6th month, just to make sure that they understand that they need to take this medicine twice a day or once a day. Again, because if you miss a few days, you're not going to have any anticoagulant on board. Dose selection, as we discussed, pretty much driven by kidney function and creatinine clearance. I think for certain groups of patients with heart failure or on potent diuretics, older individuals, where dehydration and this type of thing may be an issue. It's important to assess stability of renal function and how often should you be checking renal function. We've talked about blood pressure control and avoiding concomitant antiplatelet therapy. I think if there's anything to remember from this, it's about the aspirin and the harm when it's combined. Unless it's really important, there's an indication for it. It will only increase GI bleeding in the older population. The package insert, I think, is a great place because that's where the individuals and companies that make these drugs put everything. So that if you have a question about a drug interaction, that's the place to find it. And then to understand, the history of the bleeding and anemia, and making sure our patients are up to date on their population-based screening. So colon cancer and polyps, I think, is one important one. And then finally, I think that, with the Prax binder, daricisimab is now available, and, hopefully the andexanet alpha, which is the specific reversal agent for the 10A inhibitors, we'll gain more experience on when is it appropriate to potentially use those agents for severe or life-threatening bleeding. And so I think, actually, this was the very last slide. So to recognize that bleeding is an important side effect of anticoagulant therapy, that bleeding risk prediction models should not be used in the decision to prescribe anticoagulant therapy. And again, we can talk about that. But one question that always comes up is, what do we do with our older patients that, have fall risk? And, patients with fall risk also have very high CHAS-VAS scores usually. And remember that the CHAS-VAS score actually parallels the HAS-blood score. So many of these risk factors are the same for both. And I think with the fall, it's true. Falls are very scary in our very oldest patient population, but they also have the highest risk of ischemic stroke. And I, do my best with the VNA and getting, home health aid and getting a safety evaluation in the home and doing what I can to make sure that the patient can improve the balance at least. So not to certainly discount fall risk is an important factor. And I think with that, I can turn it back over to you.
Thank you so much, Dr. Hylek. That was great. We do have a few questions to go through. First, what are those early warning signs of bleeding that you think people should be on the lookout for, that patients should really know?
Well, I think the most common sites of bleeding are going to be the GI tract. And, excessive alcohol, using the aspirin, the ibuprofen, that's going to give, it's usually epigastric pain is where that might start. But I think the early warning sign is really the black stool. I think that that's the one that I would, and sometimes patients don't recognize it because they don't have the lights on and they're not really looking. But that's important. And what is melanoma? Well, it's black, and the stools really are coal black. And that if you see that in the toilet, that usually means that you're having a GI bleed. It doesn't come out bright red. It can come out bright red, but when it's bright red, that's usually diverticular bleeding. But when it comes from the upper tract, the blood actually tends to, it actually turns black. So that's kind of the early warning sign is really the main one that I think should be emphasized.
Oh, that's great to know. And then we got another question. You talked just a little bit about the role of vitamin K and post-blood clot diets for people who might be on one of the NOACs or aspirin or no drugs. I think they're asking, does vitamin K affect the clotting if you're not on warfarin? And then does factor V change the recommendation at all?
So the first question is about vitamin K in the diet?
Yes. So they want
okay, so this is really important to think about because, vitamin K antagonists are warfarin. What does warfarin do? So warfarin is remarkable because it really blocks the liver's ability to make these factors. So that is really an important, again, departure from these drugs. So warfarin basically blocks a critical enzyme step in the liver that allows our coagulation proteins to be activated, and then they're in the bloodstream. So when somebody's on warfarin and you measure these different levels, they will be very low because the liver's not making them. So when we talk about the DOACs, again, important to think about this. These drugs are actually molecules that block the factor in the blood, so that the factors are there. I mean, they're there just as if you didn't take your medicine yesterday. It's not like warfarin that blocks the synthesis of the factors. These new drugs just block that like on a one-to-one, almost molecular basis, so that that's the way that these drugs work. They block the active site of that particular factor. So vitamin K, eating vitamin K, oral vitamin K, dietary has nothing, zero, to do with the NOACs or DOACs. You could eat as much spinach as you possibly wanted, or kale or whatever, because it's a very different, completely different mechanism. The only kind of dietary thing that is important is that with rivaroxaban, they do highly recommend that be taken with food. But there's really no food interactions for these DOACs, the newer drugs.
That's great to know. And then our next question is about PE recovery. So it's from a 65-year-old who had a minor heart attack from a submassive bilateral PE 2 years ago. And they write that their recovery has been very slow and seems to have stopped. They have shortness of breath, palpitations, fatigue. Is it possible that their recovery has stopped? And then they ask if they could possibly have something that they call chronic fatigue syndrome.
Well, I mean, I think if there's been any kind of a change, or a patient has reached a plateau in recovery, it's, I would want to see my physician about it, and I would, press them on it. And, I think one thing that, patients tend to do is it's easy for us to sort of say, well, maybe I've sort of reached, this is as good as I'm going to get. This is about where I'm going to end up. This is my plateau. And all of a sudden, there might be something else going on. So that, I certainly don't run to the physician, I'll be honest with you, but I think it's my body if I didn't feel like something was right. I mean, I would just, I would make an appointment and see, because, fatigue can be really secondary to so many different things. So I would hate to give a flippant answer, because I think those are potentially complicated symptoms. And, I think fatigue, warrants, looking at things like the thyroid, looking to make sure there's no anemia, looking to make sure there's no depression. I mean, there's just a lot of things that, can cause that. And then certainly a feeling of being limited on a pulmonary function, respiratory-wise. I just want to make sure that there wasn't something else going on, like, reactive airways or a little emphysema or something like that.
Mm-hmm. That's great to know. And then our next question is from a man who's very active, and he bikes, rides motocross, and enjoys skiing. And he's trying to balance, his lifestyle versus his bleeding risk, because he has had blood clots in the past, PEs and DVTs. And originally, he was taken off of his Coumadin, but now has had more blood clots, and his doctors want to put him back on. And he's trying to decide between Coumadin and Pradaxa, and he wants to know, does one have a significantly less risk of bleeding versus the other? And can you comment on the risks of bleeding for people who have active sport lifestyles?
Well, I mean, this is a very personal decision. And, I think that there are so many cardiac benefits, so many cardio benefits of exercise that, I mean, I would be very reluctant to give up my lifestyle, my exercise. Now, does that mean that one has to do, Alpine World Cup skiing? Or, I think that that's a tough one. I mean, you're wearing a helmet. That's a tough question. I mean, I think riding a bike, I mean, there's probably certain levels of danger in different types of sports that we do. I mean, I would probably say that being on a shorter half-life would probably be the way to go, just because, you know, these drugs aren't going to last. They're not going to be around very long if you have a soft tissue injury or something like that. You know, I would say that if the individual is just a really super competitive athlete and has to be out there, that, and again, this is just sort of like, you know, talking with, you know, around the kitchen table, because there's no data for any of this. Right. But I couldn't even say, I mean, I would think that if there was an agent that had a reversible agent that immediately, you know, knocked out the anticoagulant, that one could argue, well, maybe that's what someone should be doing, that, you know, is really, you know, just super athletic and does a lot of different things. But, you know, the question, is it going to be warfarin? Is it going to be one of these new drugs? Again, I don't know, the liver function, the kidney function, all those types of things. But it would seem that, you know, a medication that had a short half-life and potentially the one that has, you know, a reversal agent, you know, might give a little more peace of mind. But, you know, is there any data to support what I just said? I would say no, because they're just like, there aren't studies among individuals like that. But again, I mean, these are questions that it's great to trigger these questions by, you know, webinars like this, because it gives you some questions to go back in the office and really query your physician.
Definitely. And then the next one is also along that line of, you know, something to really think about. The person is on Plavix and Xarelto, and they also take dietary supplements. So they want to know, is there a high risk that the supplements should be, or I guess, should the supplements be avoided, because do they offer any increased risk of bleeding? And then how common is dual antiplatelet therapy along with anticoagulant therapy?
So, I mean, I wouldn't have any problems with dietary supplements. I mean, that's no problem at all, and I would continue that. Regarding what proportion of patients are on, you know, we really see the increase in bleeding and over baseline, certainly with the aspirin, the clopidogrel, and the anticoagulant. Because here what we have, you know, two antiplatelet agents, but again, without, you know, knowing the full story. I mean, if I have a young individual with, you know, just had, you know, a myocardial infarction, and, you know, there's concern about a recurrent myocardial infarction, which we know happens in 5 to 10% of patients before they leave the hospital. And we know that in the first year after myocardial infarction or MI, that there's another 5 to 10% risk. So, you know, younger individuals, and when I say younger, I'm thinking like less than 70, somewhere probably in the 60-ish, 65, 60, 55 range. You know, our stomachs are different when we're in that age group. There's more prostaglandin buffering in the gastric, the stomach wall, so that we're a little less prone to the GI bleeding, the upper GI bleeding, the gastric ulcers that you can see when we get older. But what proportion of patients? Well, certainly there are patients that are on aspirin and clopidogrel, because this is going to be a patient that had a stent placed. It's going to be an individual usually with, you know, coronary artery disease. And that individual also has atrial fibrillation. So they're getting maximum protection for these two different entities. You know, you're getting the maximum protection for your AFib, which is the anticoagulant, and you're getting the maximum protection from, you know, something within the coronary circulation with the antiplatelet therapy. So, you know, that's something that there are different guidelines on when you can stop the dual antiplatelet therapy. Many guidelines now like start to drop that. At least they would be dropping the aspirin by the 6-month mark, and maybe continuing on with the clopidogrel, with the rivaroxaban. But, you know, we're learning more about this, and this is something else, like before we conclude, that I want to say, is that we do now, there are trials, and we'll have more information about what to do exactly with the patient that you were just telling me about, because it's once we understand, like if we randomize, for example, someone just like that patient to only be on like that DOAC medicine with, the clopidogrel, how does that compare to being on all three of the medicines? And I think that we'll learn that. But, it's going back to the internist and the cardiologist and, just saying, hey, is it time for me to maybe come off one of these? I'm just worried I might have a bleed, something like that.
Thank you. And then we also got another question asking, is it correct that the NOAC reversal agent is up for FDA review again in February? So I believe they're asking you to talk a little bit about Indexinet.
So for Indexinet Alpha, I really couldn't even speak to it, to be honest. I mean, this is the FDA. I know that the, what they call, I believe, the PDUFA date, I don't want to misspeak here, but I do think that the FDA is looking at this. I think there's great hope that this will be approved soon. But I also like to provide reassurance to people because, remember in the trials, all of these trials trended towards reduced mortality. All of these studies had dramatic reductions in the kind of bleeding that we fear the most, which is the intracranial bleeding. And even the fatal and the other critical organ bleedings were all reduced in these randomized trials. And these now are encompassing really like 60,000, 70,000 people. So I wouldn't want like my parent to be living in fear of some, disaster occurring, because I do think that overall these drugs look safe. But with that being said, one cannot predict things that might occur, and I think that it will be welcomed to have the reversal agent for these drugs. Now, certainly if something happens, we do have other things that we do, like prothrombin complex concentrates. I mean, there are other things in the emergency room that would help an individual stop bleeding. So it's not as if something would happen that they would be left with not having some way to intervene, because that's clearly not the case, because right now that is what's being used. They're called PCCs, or prothrombin complex concentrates. And that's in the sense of a life-threatening bleed. I mean, I've been doing medicine a long time. The vast, vast majority of bleeds, I mean, you just hold a drug. It's a short-acting drug, and these patients do fine, usually just because it's such a short half-life.
Great. And then we got a question that's a little bit off of this topic, but it's still about bleeding risk. The person asks about a drug called Celexa, and says that they've read studies that it does not show the same bleeding risks as other SSRIs, which are used to treat depression and anxiety. Do you have any thoughts on this?
Well, I mean, I think that, these medications are overall, I mean, to my knowledge, safe. I mean, I use a lot of SSRIs. I think of all of the choices we have out there to treat, various things, that they are safe. I would say I'm completely unaware of SSRIs or Celexa being, especially like picked out as increasing bleeding risk. I mean, in these trials, many of these individuals were on multiple drugs, and, the best place to get that information is whatever the medication is that the patient's on, whether it's, Warfarin, or it's apixaban, adoxaban, or, dabigatran, or rivaroxaban. As I would look in the package insert, and you can get those. I mean, it's like available probably with everything, or talk to the pharmacist, because they would be able to say what the actual data, are that support that a particular medicine like Celexa in combination would increase the bleeding risk. But I'm really not aware of that. I have not heard of that.
All right. And then someone writes that a family member was on warfarin and was regularly being monitored, but now she's not on one of the newer agents and isn't seen as regularly. She asks, how do you go about following up with patients who are on the newer agents?
Well, I mean, what we usually do when we do have someone who would like to switch, we see them, and obviously we have an anticoagulation service, and we sit down and go over all the things and early warning signs and, all of that, and help the family and help them, realize that these drugs, all these medicines were studied without monitoring because of the short half-life. So there was no routine monitoring in any of these huge randomized trials that enrolled 18,000 people really in each one of them approximately. But we follow the patient somewhat. I mean, I do think it's a breakthrough that we don't have to have our patients, tethered to being monitored, every 2 weeks and trying to get into, Boston to get their levels checked and stuff. So I do think that from that standpoint, it's a good thing. But on the other hand, for individuals that might need, a little more, I don't want to use the word supervision, but just a little more encouragement to stay on their pills because it's hard. I mean, let's not forget that adherence with almost all cardiovascular medications is about maybe 60% overall with people skipping pills, and it's incredible. But going back to the question at hand, so we, see the patient, we give the prescription, and then usually we always check renal function, obviously, before we even start the medicine. And then we usually call the patient about 1 week, like 1 week into it. And then after that, I think we do have a protocol. I think we see them in the office at the 4-week mark and then the 3-month mark. But after that, I mean, if they're not having any, odd feelings or from the medicine, there's no adverse effects, then we just, they see their doctor. And it literally can be, maybe checking in, twice a year. I mean, if the patient's seeing their geriatric doctor or they're seeing their cardiologist or their internist, I mean, the main thing is to be sure that they're taking the medicine as it was prescribed, so twice a day or once a day. And then, with the kidney function, how often do you need to check that? Well, I mean, you don't have to be checking that kidney function, more than once a year if it's normal now, or, maybe every 6 months if there's a little kidney impairment. But, you don't, that's one of the, I think, nice things about these medicines is that you don't really have to be following them as closely as we had to with warfarin.
Wonderful. Well, thank you. And then we have one last question that has been asked. They ask if you could share your opinion on testing to identify silent GI bleeding.
Silent. Well, I mean, I think that the first thing is critical is that when we hit 50, we're all supposed to be having colonoscopies. So, I mean, I think that's important. And if people are just really reluctant to go through that whole process, and I can certainly relate to that because, drinking the jug is not pleasant and it's just a tough test. But if you just push yourself through it, hopefully you'd only need it every 10 years.
Right.
So from just a practical population basis, I mean, I always make sure that my patients are up to date on their colon screening because if they had some, adenomas, then that's going to be closer follow-up. That could be 1 year for the next scope. That could be 3 years for the next scope, or it could be 10 years. So, and as far as like routine doing like the B would make a lot of sense. And then in addition to that, to be sure that they're up to date on their cancer screening.
Wonderful. Thank you so much. That was our last question. So
Great.
I'm going to say thank you so much, Dr. Hylek, for being with us tonight.
Okay. It was really, really great to do it.
And our next online support group will be on December 12th at 7 o'clock with Dr. Suresh Vedantam. He'll be talking about the ATTRACT trial and an update on post-thrombotic syndrome. Right. Thank you, everyone, for calling in tonight, and have a wonderful night.
Okay, thank you. Have a good night, everyone.